At the end of this lecture, you should be able to define shock, recognize clinical features of organ hypoperfusion, understand the physiological basis of cardiac output and shock, describe the key features of four main categories of shock, and explain the early management of patients with shock. Before we carry on, I want you to think about the question on the slide for a minute. We're going to go through a case, the details of which are on this slide. Is this patient shocked? Shock is a state where there is inadequate perfusion to the tissues to meet demand. Although hypotension frequently accompanies shock, it need not be present. This is self-evident if you remember that there are homeostatic mechanisms which maintain blood pressure even when cardiac output falls. Thus, a fall in cardiac output and blood pressure results in vasoconstriction and tachycardia in an attempt to maintain a constant blood pressure. It is only when these compensatory responses are overwhelmed or malfunctioning that the blood pressure falls. It is therefore just as important to assess the magnitude of the compensatory response. Failure of compensation indicates very severe disease. Features of tissue hypoperfusion include decreased conscious state, which may only manifest itself as confusion, cold peripheries, mottled skin, oliguria, metabolic acidosis, and hyperlactatemia. So clearly our patient is shocked. She is oliguric and confused with skin mottling. What should we do next? The immediate priority is to rapidly determine the cause of shock. This is easily done if one remembers the relationship between cardiac output, peripheral resistance, and mean arterial pressure. If the mean arterial pressure is normal but peripheral resistance is high, then the cardiac output must be low. Alternatively, if the mean arterial pressure is low, either the cardiac output must be low or the peripheral resistance must be low. As peripheral resistance is one of the two determinants of blood pressure, it is clearly vital that we assess this. We can do this by feeling the hands and feet and assessing the peripheral perfusion. Cardiac output is determined by heart rate and stroke volume, so it is vital to know the heart rate. Stroke volume is determined by preload, afterload, and contractility. Preload can be estimated, but afterload and contractility are difficult to assess clinically. So in summary, the three things that you want to assess in a shock patient are peripheral perfusion, heart rate, and JVP, CVP, pulse pressure variation, or response to passive leg raising. Going back to our patient, her heart rate is 104 per minute with a regular small volume pulse. Her venous pressure is slightly raised with a JVP 4 centimeters above the sternal angle, and her peripheries are cold. The causes of shock can be classified into four major types: cardiac, hypovolemic, distributive, and obstructive. In cardiac shock, the heart rate is usually increased, except when the shock is due to an arrhythmia, in which case it may be decreased or markedly increased. The venous pressure is raised and there is compensatory vasoconstriction in an attempt to maintain blood pressure. In hypovolemic shock, the primary abnormality is decreased circulating volume. As a result, the venous pressure is low and there is compensatory tachycardia and vasoconstriction. In distributive shock, the primary abnormality is vasodilatation. Most conditions that cause distributive shock also cause leakage of fluid from capillaries. This results in both warm peripheries and a low venous pressure. Once the hypovolemic component has been eliminated by fluid resuscitation, the blood pressure in true distributive shock will still not normalize. Shock is still present as a result of severe vasodilatation. Obstructive shock is more complicated, with the signs being dependent on the cause of the obstruction. However, in obstructive shock due to the most common causes, tension pneumothorax, massive pulmonary embolism, or cardiac tamponade, the venous pressure is usually markedly raised and there is compensatory tachycardia and vasoconstriction. The most likely diagnosis in this case is cardiogenic shock, but the physical signs and history make obstructive shock due to pulmonary embolus a distinct possibility. What should we do next? The immediate resuscitation of patients with cardiogenic shock and obstructive shock due to a pulmonary embolus is similar, so making a distinction between the two at this stage only wastes precious time. If a shock patient has immediately life-threatening hypotension, give epinephrine boluses followed by a vasopressor infusion to buy time. Otherwise, initial treatment usually consists of fluid loading, almost regardless of the cause of the shock. The major question of how much fluid is dependent on the cause of the shock and the treatment goals. In general, treatment goals are to restore normal cardiac output and an adequate blood pressure. Organ blood flow is autoregulated within a certain range of blood pressures, but below and above this range, flow is dependent on pressure. It is therefore important to keep the systemic blood pressure within the limits of autoregulation. It's easy to see how a blood pressure below the lower limit of autoregulation will result in an inadequate organ blood flow. Furthermore, in the critically ill, autoregulation may be impaired, making blood flow even more dependent on pressure. Returning to our patient, we should start a fluid infusion and give oxygen. Only then should further investigations be carried out. These are aimed at assessing the severity of circulatory failure and to determine the cause of shock. The ECG shows an extensive anterior infarct, confirming the diagnosis of cardiogenic shock. We're going to pause here for a minute. Think of two important learning points from the lecture so far and why you think they are important. Now we can address the issue of how much fluid we should give. In most patients, an increase in fluid loading will result in an increase in cardiac output. However, many doctors are reluctant to give fluid, particularly to a patient with a raised JVP, because they are afraid of causing pulmonary edema. In most patients with cardiogenic shock, the compliance of the ventricle falls, with the result that the end diastolic pressure volume curve or compliance curve shifts to the left and up. For any given end diastolic volume, the end diastolic pressure will be higher, and hence the atrial pressure will be higher. Under normal circumstances, we operate on the flat part of the compliance curve. As a result, even when the compliance falls, the patient is still likely to be on the flat part of the curve. Giving the patient fluid should therefore increase the end diastolic volume and hence the cardiac output without significantly increasing the end diastolic pressure. As a result, giving small boluses of 50 to 100 mils should not result in significant pulmonary edema if the effect of the fluid boluses is carefully monitored. What if fluids are not enough? In simple terms, give an inotrope to increase the cardiac output and a vasopressor to increase the blood pressure. Dopamine is an inotrope, chronotrope, and vasopressor with concentration-dependent effects. Its vasopressor effects are most marked at high doses. Because of its vasoconstricting effects, it should not be given through a peripheral line except for a short period of time until central venous access can be obtained. Extravasation of dopamine results in very high concentration in the subcutaneous tissues, with a resultant intense local vasoconstriction and necrosis of the overlying tissue. Dobutamine is an inotrope, chronotrope, and vasodilator. Because of its vasodilating effects, it often reduces blood pressure and should not be used on its own in markedly hypotensive patients. Norepinephrine, which is almost a pure vasopressor and which has little or no effect on cardiac output in healthy volunteers, will often increase cardiac output in hypotensive patients. This is because cardiac output is often reduced in hypotensive patients because the hypotension results in decreased coronary perfusion. By restoring blood pressure and hence coronary perfusion, norepinephrine improves left ventricular function and hence cardiac output. Returning to our patient, we know coronary perfusion is already impaired. The LV is only perfused during diastole, so the LV coronary perfusion pressure is dependent on diastolic pressure. LV perfusion is also dependent on the duration of diastole, which will be disproportionately reduced by tachycardia. The aims of initial management of most cases of cardiogenic shock are, therefore, to restore an adequate diastolic pressure without causing tachycardia and to increase cardiac output. In a normotensive patient who is nonetheless shocked, the appropriate treatment is infusion of dobutamine. In the frankly hypotensive patient, the appropriate treatment is norepinephrine to restore diastolic pressure first, and then dobutamine if necessary. It is important to realize that the dose-response curve for all inotropes and vasopressors is shifted to the right and often down in critically ill patients, particularly those with sepsis. It is more logical, therefore, to titrate the dose against the effect rather than to strictly adhere to a textbook dose. This is made easier by the rapid onset of action and short half-life of these drugs, which is a matter of 2 to 3 minutes. As a result of this, a new steady state is reached very rapidly after any dose adjustment. The patient should be assessed frequently and dose adjusted to ensure that the target effect is achieved rapidly. A frequent question is, in practice, how much should I give? And the answer to that is enough. This is not as facetious as it sounds. Because of the shift in the dose-response curve, what we do is start with an initial dose, recommended initial doses are given in your books, and then rapidly titrate the dose, increasing it if the blood pressure is too low and decreasing it if it is too high. The overall time frame should be such that you should stay at the bedside until hemodynamics have stabilized. Patients with cardiogenic shock should probably also be referred early for revascularization. As always, it is vital to treat the underlying disease. Turning now to other forms of shock. In hypovolemic shock, the answer to the question of how much fluid is relatively simple and is determined by the amount of fluid that has been lost. Remember that a loss of 10% of circulating volume usually produces no signs or symptoms, and a loss of up to 30% may be required to produce frank hypotension. Fluid challenges of a litre of crystalloid should be given and the response assessed. The primary treatment of hypovolemic shock is fluid replacement and treatment of the underlying cause, but patients may require vasopressors for life-threatening hypotension and in the later phase when they may develop distributive shock as a result of the tissue injury that led to hypovolemia. As mentioned earlier, the problem in septic shock is a combination of vasodilatation and capillary leak. Patients often require large volumes of fluid. The fluid balance is of no value in determining the need for further fluid loading in the initial 24 hours because of the unknown degree of capillary leak. Again, give fluid challenges of a litre of crystalloid. In septic shock, the primary problems are severe capillary leak and vasodilatation. These patients should be given vasopressors such as norepinephrine or epinephrine to restore blood pressure and then dobutamine if there is evidence of ongoing tissue hypoperfusion. Dopamine is associated with a high risk of arrhythmias and should be reserved for patients with a very low risk of arrhythmias and with low cardiac output. Obviously, it is also vital to treat the underlying cause with source control and antibiotics. The management of obstructive shock is more complicated because the initial treatment depends on the pathophysiology of the underlying cause. For example, initial management of tension pneumothorax is needle thoracostomy, while initial management of massive pulmonary embolism is a bolus of 100 to 250 mils of crystalloid. Note a chest drain should always be inserted after needle thoracostomy, regardless of whether pneumothorax was present or not. Management of obstructive shock is complex and expert advice should be sought at an early stage. Although the cardiac output is low, dobutamine is not the optimal agent in most cases because its vasodilatory effects may result in severe hypotension in the presence of a relatively fixed cardiac output. Norepinephrine is probably the best choice for initial management. Write down 3 key learning points from the lecture, 3 things that you think would be important to tell a colleague who has not heard the lecture. I'll give you a minute to do this. In summary, early shock is diagnosed by assessing tissue perfusion. Use the temperature of the peripheries, heart rate, and JVP to distinguish between hypovolemic, distributive, cardiac, and obstructive shock. Resuscitate to restore cardiac output and blood pressure, and identify and treat the underlying cause.